a case of a 70-year-old male patient who presented with severe right shoulder pain after a direct violent trauma, no associated injuries. This was the initial radiologic evaluation, the X-ray on the left. It is a AP thorax view. It is not an IP true view of the shoulder, though I think it is a pertinent view for acromial injury and AC joint injury too. And the one on the right, it is a scapular wide view. It gives us a profile view of the scapula, and this is a pertinent view to assess suspected scapular fractures. As we can see, there is a displaced fragment of the acromial process with disruption of the AC joint and a reduction of the subacromial space. Despite the AC joint disruption, as we can see here in the AP thorax view, the CC ligaments, I mean the coracoclavicular ligaments, didn't suffer during the injury. So I believe that just fixing the fracture it's enough. Maybe this kind of lesion behaves as a type 2 of Rockwood classification for AC joint dislocation. So we can solve this problem without addressing the AC joint. This is an axial CT scan view. Here we can see that it's a kind of distal fracture of the acromion process. And following Kahn's classification, we can say it's a type 3 because we have a displaced fragment with a reduction of the subacromial space. As it is a distal fragment, some can consider the excision of the acromial fragment. This has been reported, but it can result in substantial weakness of the deltoid muscles, and this is something we have to avoid. So I would recommend to fix the fracture. Moreover, as we know, the acromion provides one side of the AC joint and serves as the point of attachment for the deltoid muscle and the coracoacromial ligament, which provides anterior superior stability to the glenohumeral joint. In addition, the acromion, by being part of the roof of the glenohumeral joint, it provides posterior superior stability too. And finally, as it is a type 3 type of fracture, the subacromial space is compromised by the inferior pull of the deltoid muscle on the acromial fragment. So open reduction and interfixation is advocated to prevent secondary impingement too. We can decide between tension bind wiring, Kitchener wire, staples, lag screws, and even plates. But as it is a distal fragment, I decided to do some tension bind wiring. I perform an open surgery with the patient in beach chair position under general anesthesia and an interscanal regional block. I perform a vertical incision following Langer lines. I believe that the success of this procedure depends on the fracture fixation itself, but on the biologic healing too. So here the dissection should be done proximal to the anterior end of the acromion process, since the vascular supply comes from the anterior part. Okay, so this is how I fix the fracture using the tension bind wiring. Some plain X-rays were performed during the first day post-operatively just to document fracture reduction. This is axillary view at the same point of time. The blue arrow is at the location of the acromion process fracture. These are some X-rays 4 weeks after the initial surgery. So the patient was placed on an arm pouch sling for 4 weeks. After that time, the sling was discontinued and active range of motion and physical therapy was initiated. At 3 months of follow-up, the patient suffered this kind of complication, maybe a skin irritation from the inside. I believe that one of the key wires was too proud, so I decided to remove all kinds of implants, and these are the final X-rays in an thorax view and axillary view. You can see the fracture healing and the subacromial space restored. This is a CT scan comparison at 6-month follow-up between that point of time and the initial CT scan, where we can see that the fracture has already healed and bone remodeling too. But this is a CT scan at the same point of time in a coronal view. Thank you very much.